Alright guys, good evening. Eh, okay, can you all see me? Can you all hear me? Are we live? Second. Alright, yeah, good evening guys, good evening. Hi Paul, good evening. So, can you all see me? Can you all hear me? Can we start the visual treat? That's gonna be important from our exam perspective. Happening. Okay. Here now. Can you all see me? Can you all hear me? Good evening guys, good evening. One second. Somehow. Give me a second. Hi, good evening, guys. One second. I'm trying to sort out. Okay, I think I'm good here. Okay, please combine find with honors also. I did not understand what you're trying to say. Getting just give me one second. Stream yeah. भाई क्यों मतलब यहाँ पे तो सब ठीक है ना. Okay, now I think it is live. ठीक. Okay. Okay. Yeah, guys, just give me a second. We are about to start. All right. So I think this is good to go. Okay. Now, we'll start discussing all the important images which are there in general surgery. We'll try to do a quick recap of all the images. The image based and one-liners, yes. I'll tell you a lot of important points as we go across, more or less like a one-liner only. Okay, so let's begin. The first one is going to be about the drains. The first drain that you can see, I'll just number them as we go across. This is drain number 1, and this is what we call it as the corrugated drain. This is what we call as the corrugated drain. Now, when you talk about the drains, the first thing you should know what is the material. You can see if it is a yellow, orange colored material, it is usually rubber, so it is going to be latex. Okay. Third thing you should know in a drain, that is it an open or a closer drain. Obviously, you can see there is no bag attached to it, so this is an example of an open drain. And then does it work on the principle of dependent drainage, or does it work on the principle of negative suction? You can say it's a dependent drainage, so it is going to be a passive drain. It is going to be a passive drain. So the image number 1 that you have is an example of a corrugated latex drain, which is an open drain, and it works on the principle of passive passages, and this is what we call it as the passive drain, right? Now then you have the image number 2. Now the image number 2, this is also an example of a corrugated drain. This is also an example of a corrugated drain. And when you see, if it's a transparent color, then it is going to be silicon. It is going to be silicon. Again, this also classifies as open drain. And this also works on the principle of passive drainage. So this is also an example of a passive drain, right? So it's a corrugated drain, it's a silicon drain, it is an open drain, and this is an example of a passive drain. Clear? Now, then you have the image number 3. Nobody can ever forget this image. This is going to be your Foley's catheter. It's a Foley's catheter. Remember, it is a self-retaining balloon catheter. It is a self-retaining. This is a self-retaining balloon catheter. It is a self-retaining balloon catheter. Absolutely correct, right? So when you look at the self-retaining balloon catheter, you should know that whenever you talk about it, there are two things that you should know. One is the entry point. This is to inflate the balloon. So this is what we call it as the inflating channel. This is what we call it as the inflating channel. And this you can see it is for the urine collection. The urine collecting channel, right? Somewhere across here you will have the balloon which is present here, and distal to the balloon there will be a small opening. This is what we call it as the eye of the Foley's catheter. Now the eye of the Foley's catheter is where you will collect the urine from, as simple as that. So it's a self-retaining balloon catheter. It has got an inflating channel, there's a urine connecting channel, there's a balloon and an eye. We have more detailed discussion when you go to the Euro images, right? Now here they can ask you is, whenever you're inflating the balloon must be inflated with. So whenever you're going to inflate the balloon, remember, do not use air because it is going to float up. If you use any of the crystalloids, it will precipitate into crystals and deflating the balloon will become difficult. So the balloon is always inflated. It must always be inflated with distilled water. This must be inflated with a distilled water, right? Then you have the image number 4, right? So the image number 4 is also a Foley's catheter, but you can say this is 1, 2, 3. So this is what we call it as a three-way Foley's catheter. It's a three-way Foley's catheter. It is used for bladder irrigation. So whenever you've done any bladder surgery and you don't want the clots to get accumulated, for bladder irrigation, we'll be using a three-way Foley's catheter. Now in a three-way Foley's catheter, again you can see the first channel which is here. It is going to be for the balloon inflating channel. For the balloon inflating channel. The bigger channel which is present here, this is for urine collection. This is for urine collection. And a smaller channel which is present here, this is an irrigating channel. This happens to be a irrigating channel, right? So you have the balloon inflating channel, you have the urine collecting channel, as well as your irrigating channel. So all these are important with respect to the three-way Foley's catheter. So the question in the exam that they asked is, number 1, identify the image, and number 2, the advantage or the usage of three-way Foley's catheter. The usage of a three-way Foley's catheter. The usage of a three-way Foley's catheter is going to be for bladder irrigation. My screen is stuck. 1 second. Okay, I think it's working now. Yeah. So it's a three-way Foley's catheter, right? Now, you go into the next image, the image number 5. The image number 5 is what we call it as the Penrose drain. The image number 5 is an example of a Penrose drain. We don't use it any longer. This is also an example of an open drain. This is an example of an open drain, and this also works on a principle of passive. This is also example of a passive, right? Bharat is saying lagging. Okay, is anybody else facing any other issue? Anyone facing any other issue, guys? Quick feedback. हेलो, क्या इशू क्या है? मेरे यहाँ पे तक मैं मोबाइल पे एक्सेस कर लूँ नहीं तो. Guys, sorry, there's some issue on the YouTube side. It seems some glitch that has been. I think you are getting a proper stream. I'm not able to stream it. Uh, just give me 1 second. I'm going to access it from a mobile so that I get it across. Yeah. Okay. Now in the mobile it is perfect. Okay. Okay. I hope. Okay. While we stuck over. Okay. Let's go down there. So image number 6 that we have. This is what we call it as the Romo back thing. Now this is going to be important from our exam perspective. They've asked you the image, they've asked you the same component here. So when I say a Romo-Vac drain is an example of, number one, it is an example of a closed system drain. So it's a closed drain. This works on a negative pressure. The pressure that you can create by just squeezing the Romo-Vac is what we call it as the negative suction drain. So this works on the principle of active drainage. It's an active drain. It works on the principle of negative suction. It works on the principle of negative suction. So important points about the Romo-Vac drain that you have to remember is, remember when you talk about Romo-Vac drain, you usually put this in the thyroid surgeries and the breast surgeries. I can put in a lot of one, but usually we put in the thyroid as well as the breast surgery, right? So in the thyroid surgeries, remember Romo-Vac drain is removed after 24 hours if there is no hemorrhagic collection, and this is removed after the 5th day if there is no collection, right? So this is the removal of the Romo-Vac drain, again an important exam question, right? Then the image number 7 that you can see here, this is what we call it as a T-tube. This is what we call it as the T-tube. Now the T-tube that is going to be used in CBD exploration. So after a CBD exploration, you're going to put a T-tube. After you do a CBD stone extraction, by open method, this is what we call it as a T-tube orientation. So the function of the T-tube is going to be after a CBD exploration, and then you're going to put on a CBD stone extraction via an open method, right? Now another interesting thing that you need to know with respect to the T-tube, another important thing that you should know with respect to the T-tube is, now when you take via the T-tube, when you take an axis to bring the stone out, that is what we call it as the Bruhane's technique, right? So when we talk about the Bruhane's technique, it is to remove the stone via, it is stone extraction, it is stone extraction via T-tube. It is a stone extraction via T-tube. That is going to be about your T-tube's orientation. Then you have the image number 8. Now the image number 8 is what we call it as the pigtail catheter. It's a pigtail catheter. Now how do you know it's a pigtail? Number one, you can see with the stillet, you can see, if you see inside this, you can see all this within the holes, you can see that there's a metallic tube which is present, right? That is called as stillet. When I pull this stillet, you can see it is going to coil from one end, so it is called as a pigtail catheter. Then you have the image number 9, again a very important one. This is what we call it as the nasogastric tube. This is what we call it as a nasogastric tube, or popularly referred to as the Ryle's tube. Now this is used for feeding as well as to decompress the stomach per se, right? Now the question about the nasogastric tube, if all you guys are there listening, a very simple question. Number one, what is the total length? What is the length of the nasogastric tube? Approximately how much is the length? The length of the nasogastric tube is going to be 100 centimeters, that is 1 meter. Now what is the rule to measure the length of the nasogastric tube that you want to push it inside, right? So we talk about the nasogastric tube adequate length. So how do you calculate the adequate length? The adequate length of nasogastric tube to be pushed. Very good. To be pushed, the rule is what we call it as the next. The rule is what we call it as the next rule. Now, what is this next rule is? Now, identify, imagine that this is the patient that you have, and this is the orientation of the patient, which is here. This is the neck of the patient. This is the thorax of the patient, let's say. This happens to be suprasternal notch. This happens to be sternum. This happens to be sternum. The next rule states that take a tube, measure from the tip of the nose to the earlobe, from the tip of the earlobe to the xiphisternum, and this is what we call it as the nose, ear, and xiphisternum, called as next roll. So you measure from here to here, from here to here, whatever is the length, whatever is the length that you have is what we call it as the next. This is what we call it as the next rule for the nasogastric tube insertion. Clear? Okay. So this is what you have to remember with respect to the nasogastric tube component. Now the image number 10 that you have is your previous exam question, right? So the image number 10 that you have, this is what we call it as the Jackson-Pratt drain. This is what we call it as the Jackson-Pratt drain. Now when it comes down to Jackson-Pratt drain, this is also an example of a closed drain. This is an example of a closed drain. Along with the closed drain, this works on the principle of active drainage. It works on a principle of active drainage. That's your Jackson-Pratt drain. Absolutely correct. Yeah. The flat tube and the bulb. Absolutely correct. You can see there's a flattened tube with fenestration, right? And then you have a collecting bulb. You squeeze that bulb, it generates a negative pressure, and that pressure is good enough to pull the secretions out. Jackson-Pratt is now not that famous because since we have the Romovac drain, we now resort to Romovac drain, which appears to be a much more better option when compared to a Jackson-Pratt drain. Okay. Okay. Then you have the image number 11, which is here. The image number 11, which is going to be here. N2RA, we will start the final year batch sooner, but now we are talking about all the students who are going to go to write their NEET and INI-CET. We're focusing on that. Okay. Now this is what we call it as a SBT tube, that is your Singastkin. It is the Singastkin. ECMO tube. It is your Singastkin ECMO tube. It is your Singastkin-Blakemore tube, which is also called as SBT. Now, can anyone tell me what is the major use of the SBT tube? Also called as the SBT Singastkin-Blakemore tube. The major use of the Singastkin-Blakemore tube, it is to control the bleeding in the esophageal varices. This is basically to control. It is to control. It is to control hemorrhage from bleeding esophageal varices. From bleeding esophageal varices. From bleeding esophageal varices, right? Now, what you have to know is there are two balloons which are going to be present. This is the balloon number 1, this is the balloon number 2. The balloon number 1 is what we call it as the gastric balloon. This is what we call it as the gastric balloon. And the balloon number 2 is what we call it as the esophageal balloon. It is what we call it as the esophageal balloon. Now, both of them, when they're inflated, they are going to be inflated with air. So, the esophageal balloon as well as the gastric balloon, I'm going to put the air. Yes, Vijay Lakshmi, you're spot on. When you talk about the gastric balloon, I'm going to inflate it with 300 ml of air. When you talk about the esophageal balloon, I will inflate with 40 millimeters of mercury pressure. This is the most important precaution that you need to know. Another thing is, any patient who is being put an SBT tube, the most important precaution is it has to deflate the balloon every 12th hourly. Deflate the balloon every 12th hourly, or it increases the risk of pressure necrosis. It increases the risk for pressure necrosis, right? So this is about your SBT tube or the Sangaskian-Blakemore tube. The other tubes which can exist with a similar purpose, number one is going to be your Linton tube. Another one is the Minnesota tube. Another one that you have is going to be the Minnesota tube, right? Both of them work on a similar principle of the Sangaskian-Blakemore tube. For the exam perspective, SBT tube is important. Every single component that we have spoken is going to be important. Yes, Minnesota. See, Minnesota tube, when you talk about it, there are 4 channels, right? 2 aspirating channels and 2 balloon channels. That's it. That's the only thing they can ask you. In the yeah, somebody has answered that also. Very good. The Minnesota tube is going to have 4 different channels. They're going to have 4 different channels. Absolutely correct. Okay. So this is about the first set of images that you have. Now, going into the second set, I will call this as the image number 12, where you will have all the images, right? So this is about the color code of the cannula and the flow rate. That is going to be absolutely important, right? Now, when you talk about the color code, you have the first one, orange. Orange is going to be 14 gauge needle with a flow rate of 240 ml per minute, right? Now you have the second one, which is, so the first one is going to be orange. The second one is going to be gray. Gray is going to be 16 gauge with a flow rate of 180 ml per minute. Then you have the green colored cannula. The green is going to be 18 gauge with a flow rate of 90 ml per minute. With a flow rate of 90 ml per minute. Then you have the pink colored cannula. The pink is going to be a 20 gauge with a flow rate of 65 ml, or I can say it is 60 to 65 ml per minute, right? Then you have the blue colored cannula. The blue is going to be a 22 gauge with a flow rate of 30 to 35 ml per minute. Then you have the yellow colored cannula. The yellow cannula is going to be 24 gauge with a flow rate of 20 ml per minute. The last one that you have is violet, or also called as purple, a 26 gauge cannula with a flow rate of 12 ml per minute. With a flow rate of 12 ml per minute. So here you need to know the size, the color code and the flow rate of each individual cannula. That is important. Now the major problem is, how do you remember the color coding of each one of them? So for that we have a small mnemonic, right? So what is the mnemonic? Is the core of the earth is made up of lava. The lava is orange in color, right? Above the lava, what do you have? You have the soil. The soil is gray in color. On top of this gray soil, we have this green tree which is going to be present. On top of this green tree, you have this pink flower which is going to be present. On top of this pink flower, you have the blue sky. This is the blue sky that you have. Now, within this blue sky, you have a yellow sun. You have a yellow sun there in the blue sky. And then beyond this you have the universe, and obviously universe is going to be darker in color, so I'm just showing you universe to be in violet. So this is going to be universe, which is going to be violet in color, right? So when you look at the stars, this is how the stars. So when you look at the entire components, this is orange is 14 gauge, soil is 16 gauge, trees are 18, pink is 20, sky is 22, sun is 24/7. This is your violet, right? So this is how you're going to remember the color code and its flow rates. Clear? Right? So this is how you're going to remember the color code and its flow rate. Yeah. So it's about your various cannulas and its color code. So moving on further. Now this is about the minimal invasive surgery. So this was your image number 13. This is your image number 13. Yeah. I hope everybody is able to stream well. Chat box. Okay, fine. Hoping everything is fine. Moving forward with a leap of faith. In the minimal invasive surgery, so laparoscopy, we'll be talking about the MIS, that is minimally invasive surgery. To talk about the MIS, that is a minimally invasive surgery, right? Yeah. So when you look at the image, I have the image capital A, small a, capital B, small b, right? Now, the one which is going to be hollow, this is going to be hollow. Now, the hollow structures are what we call it as port, and the solid structures is what we call it as the trocar. So when you touch them, this is going to be hollow, this is going to be solid, solid is going to be trocar. Now, bigger one is what we call it as a 10 millimeter port and a 10 millimeter trocar. This is going to be a 5 millimeter port. This is a 5 millimeter port and a 5 millimeter trocar and a 5 millimeter trocar. Yeah. Now this is the first image. The second one, you can see most of the trocars, whenever you see, you will have a very pointed end, right? They're always pointed and sharp. What if you have a blunt ended trocar? Now whenever you come across with a blunted trocar, then it is what we call it as the Hansen's. Now Hansen's port is basically a atraumatic port. Hansen's port is an example of a atraumatic. This is an example of an atraumatic port. Then you see this. This image is what we call it as SILS. SILS stands for single incision laparoscopic port surgery. SILS stands for single incision. The single incision laparoscopic port, and this is what your SILS stands for, single incision laparoscopic port surgery. Now you can see there is one single port and there are 4 axes, right? A single port with 4 axes is what we call it as SILS. That is a single incision laparoscopic port surgery. Then comes this. Now this is what we call it as the lens. It is not called as camera. Do not misinterpret this as camera. This is the lens, right? Now when you look at the lens, yes, Vijay Lakshmi, you are absolutely correct. The problem with the SILS is when you put all the 4 instruments from the same port, they will fight with each other. So it has got very poor ergonomics. It has got a very poor ergonomics. Now because of poor ergonomics, it is no longer preferred. So it is not a popular option. It is not a popular option. Absolutely correct, right? Coming back to this one, this is what we call as lens, right? So when you look at the angle that which we are going to use, now this is the angulated lens that we have. So this is going to be a 30-degree lens, right? So the lens that we use here is going to be a 30-degree lens. With a 30-degree lens, it provides you with, so when you look at the viewing angle, now this is becomes a viewing angle. So with a 30-degree lens, I will have a wide viewing angle. And because the lens is a 30 degrees, I will have a wide viewing angle. It is going to have a wide viewing angle. It is going to have a wide viewing angle, or a wide view angle is going to present it. Now, when you talk about it, there's something called as a camera head. So when you look at the camera head, you will see all the controls will be present on the camera head. So this is how the camera head will look like, right? So this is the camera head, which is going to have all the controls and the consoles. Everything will be present here, right? Now to this camera head, we usually have a latch. To this latch, you have your lens is going to be attached. So you take the lens and you attach it to this camera, and as you know, the lens is going to be at 30-degree angle. So when you take the lens inside, it is now going to have this wide viewing angle. So do not get confused with the concept that the outer covering that you have here, this is what we call it as the camera, and this one is what we call it as the, okay. That's a basic thing that you should know with respect to laparoscopy. Now they'll ask you what is the most commonly angle of the lens that is going to be used. Currently we use for all laparoscopic surgeries a 30-degree lens. Next you have is this, right? So this is the rock star of our exam. So many times they've only asked you this, and this is what we call it as the Veress needle. Now Veress needle, it is used to create pneumoperitoneum. It is used to create pneumoperitoneum, as all of us know. Now, what is the most common gas used to create pneumoperitoneum? What is the most common gas used to create pneumoperitoneum? No points for guessing. It is going to be carbon dioxide. It is going to be carbon dioxide. Now, what is the initial flow rate? It is the initial flow rate of carbon dioxide to create pneumoperitoneum. What is the initial flow rate to create a pneumoperitoneum? Any idea? It is going to be 1 to 4 liters per, right? 1 to 4 liters per minute. Now, if I say what is the maximum flow rate, how much should be the maximum flow rate of carbon dioxide? But the range is 1 to 4, 2 to 3 is the most commonly one. You can put anywhere between 1 to 4 liters is the initial flow rate. The maximum flow rate that you can take is going to be 20 liters per minute. What should be the intra-abdominal pressure during this? How much should be the intra-abdominal pressure? It should be maintained between 12 to 15 millimeters of mercury. It should be maintained 12 to 15 millimeters of mercury, right? Now, when you're entering into the abdomen, entry into the abdomen is facing which side? Will you push the Veress needle towards the pelvis or towards the xiphisternum? You have to insert the Veress needle into the abdomen. No. So what is the entry point into the abdomen? Is it going to be towards the pelvis or towards the xiphisternum? Any idea? It is now going to be towards, pelvis. It is going to be towards pelvis. Just hold on for a second, guys. Just give me 1 second. Take down, I'll be back in a second. Just 1 second. Somebody's at the door. 1 second. All right, back on back. Okay. Now, as I was saying, the entry into the abdomen is going to be towards the pelvis. That is very important. Now, another important question that they'll ask you is the angle between needle and body. Angle between needle and body during entry. The angle between the needle and the body during the entry is going to be 45 degrees. But the angle between the needle and the skin, the angle between needle and skin during entry, it is going to be 90. Every single point that I've mentioned about the varus needle is going to be very, very important from our exam perspective. Now, your previous exam in our INI-CET, what did they ask you? They asked you about the laparoscopic ergonomics. I do believe it is an overhauled from an undergraduate point of view, but let's understand this. Let's say this is the patient. Let's say this happened to the trunk of the patient. Let's say this is the lower limb. This is the thorax, and this happens to be the arm of the patient, right? Now, for the sake of understanding, let's say this is the umbilicus of the patient. Now, there are three instruments that are going to go into this. Number one is going to be the camera port. So, I'm saying this is the optical axis. Along with the optical axis, I will say that will be two working ports which are going to go. This is the working port number one. This is the working port number two. So, imagine that we're using three instruments to work it up. Okay? There are the three instruments that are going to go inside this. Now, when you look at this, when you look at these, now I've given you three components here. This is the working port 1. This is your camera, which is called as an optical port, and this is the working port number 2, right? Yes, Gautam, you are correct. They asked you about azimuth angle. We'll try to see what is an azimuth angle is. Now remember the angle between any of the instrument and the body. The angle between any instrument and the body, this is what we call it as the elevating angle. This is what we call it as the elevating angle. The angle between the optical port and the working port, right? Sorry. This is what we call it as the azimuth angle. This is what we call it as the azimuth angle. And the angle between the two working ports, it is what we call it as the manipulating angle. This is what we call it as the manipulating angle, right? The angle between body and any of the instrument. So we can say this extends to all of them. The angle between the body and any of the instrument is what we call it as elevating angle. The angle between the optical and the working port is what we call it as the azimuth angle. The angle between the two working ports is what we call it as the manipulating angle. And remember, this was our exam question. They have asked you what is the azimuth angle basically is. Yeah. Yeah. So this is with respect to your image number or set number 13. Clear? This is about your minimal invasive surgery. Can we move on? Going on to set number 14. Now this is going to be about the energy devices. Now the four energy devices that you should know: the monopolar, the bipolar, the harmonic, and the thunderbeat, right? So let's see what is the objective here. Now what is the energy source? When you talk about the energy source for each individual, monopolar is going to use electrical energy. Monopolar is going to use the electrical energy. Bipolar will also use an electrical energy. Harmonic do not uses an electrical energy. It is going to use a vibrating energy. It is the force generated by a vibrating energy. It is going to be vibrating energy. Thunderbeat is a combined energy source. It is a combined energy source. So when I say combined energy source, this is going to have a combination of both electrical energy. This is going to have both electrical energy as well as the vibrating energy, which is going to create friction that causes heat and causes protein denaturation, right? So that's about the first is electrical energy. Now their ability to cut through the tissue and to coagulate the tissue. Can this cut through the tissue and can this coagulate the tissue? Remember, all of them has the ability to cut as well as coagulate. Let it be monopolar, bipolar, harmonic. The Thunderbeat second generation can also cut and coagulate as well. Now, when it comes down to the when you talk about the harmonic scalpel, remember this is considered to be safest energy device. This is the safest energy device in patients with pacemaker. It is the safest energy device patients with pacemaker. Now the vibrating frequency is, it is going to vibrate at 20,000 to 50,000 hertz. This is the vibrating frequency that is going to be generated, right? Now when you have the cut, mostly if you talk about the color code, I hope everybody knows it. The cut is going to be a yellow colored button and coagulate will be with a blue colored button. So when you have the monopolar and bipolar pedals as well as the buttons that you have, you will see the cut is going to be by yellow and the coagulation is going to be via blue. Next is the cut current and the coagulating current that you see. Now when you talk about, whenever we are going to plot a graph between the cut current, and the coagulating current. The cut current and the coagulating. The cut current and the coagulating current, right? So usually whenever you have to plot the graph, we will plot the graph between the voltage and the frequency. So on the y-axis, we will take the voltage. On the x-axis, we will take the frequency. Same thing we are going to plot it with coagulating current also. On the x-axis, we'll have voltage, sorry, y-axis, and on the x-axis, I'm going to have the frequency. On the x-axis, I'm going to have the, right? Now, in a cut current, you will see there will be low voltage, but there will be very high frequency. Low voltage and high frequency is what you will see in a cut current. In a coagulating current, there will be high voltage, but there will be low frequency. So the coagulating current is going to work, right? So in a cut current, there will be low voltage. There will be low voltage, but it will have high frequency. There will be low voltage and high frequency. For a coagulating current, it will have a high voltage. It will have high voltage, but it will have low. This will have high voltage, but it will have low frequency, right? So this is about the cut and the coagulating current, right? Yeah, for cut, it is going to be a continuous current. For coagulating, it is going to be an intermittent current. Okay. So this is about our set number 14. Yeah. Now going to set number 15. Now this is now getting quite popular from our exam perspective, right? So every single exam, they're trying to attempt one question at least on this. Yeah. So we have the various surgical positions. The most common complication is exit burns in monopolar. Okay. If you talk about the safety, somebody has given me a point. Yes, it is important. Now, when you talk about it, the harmonic scalpel does not conduct at all. The Thunderbeat has the same circuit as a bipolar. So all these three are safe. When you talk about the monopolar, if the cautery pad is not put properly, the monopolar is associated with exit wound burns or the exit burns, or we can say the exit current burns that is going to be present, right? So the complication that I can list here is going to be an exit current burn wound. That's the most common complication. Absolutely correct, Vijay Lakshmi. Thank you. Now, let's go ahead with the patient positions, which are going to be quite important. We'll quickly run through them, right? So when you look at the position number one, patient is lying down flat, and this is what we call it as the supine position. This is what we call it as the supine position. If the patient is going to be face down, you can see patient is sleeping face down. This is what we call it as the prone position. This is what we call it as the prone position. But a cautery pad is used. Sometimes the pad is not connected properly. If it is dislodged, you forget to put a cautery pad, then the patient can land up with the following complications, right? Now, in the image number 3, you can see the patient is put on the lateral sides, right? So this is what we call it as the lateral decubitus position. This is what we call it as the lateral decubitus. Now, this is the position that we commonly use for thoracotomies, for kidney surgeries. So this is used for thoracotomy, that is to open or entry into the lungs. It is also used for your renal surgeries. Right? So these are your lateral decubitus position, right? Now, along with the lateral decubitus position, the position number 4 is for your perineal surgeries, and this is what we call it as the lithotomy position. Now, when you talk about the lithotomy position, remember the lithotomy position is performed for perineal surgeries, for all your perineal surgery, for all your perineal surgeries, all your gynecological procedures, all your gynecological procedures, and all your endo-uro surgeries, all your endo-uro surgeries, right? Now, the problem here in a lithotomy position is you need to have the hip flexion at 90 degrees and knee flexion is also at 90 degrees, right? So the knee can be semi 90, but the most important, it requires a hip flexion at 90 degrees, right? Yeah, I was asking a question that what nerve damage can you expect in a lithotomy position? Remember, in the lithotomy position, the most common nerve injury associated with the lithotomy position is your common peroneal nerve. It is a common peroneal. It is going to be a common peroneal nerve. Got it? Okay. So this is about your lithotomy position, right? Then you have certain variations. So standard ones are these four. You have the supine, you have the prone, you have the lateral decubitus, and you have the lithotomy position, right? So the question that was asked is, what is a nerve injury in a lithotomy position? We all know it is a common peroneal nerve injury that is going to occur. Next goes to the variation of this. Now, can you identify this variation? The first variation that I'm showing you. This is what we call, this is a prone position, but it is now the table is broken so that the bottom or the lower part gets extended for a better exposure. This is what we call it as a jackknife position. This is what we call it as the jackknife position, right? The problem with the jackknife is it is going to increase the risk for asphyxia. It increases the risk for asphyxia. So now it is not preferred, right? Can you tell me this position? So here you can see normally in a lithotomy position, as we have mentioned it before, in a lithotomy, I would want the hip to be flexed at 90 degrees, right? In a lithotomy, I would want the hip to be flexed at 90 degrees, but here you can see there is a much wider angle at the hip. There's a wider angle at the hip. Can anybody identify this position? The second position? This is what we call it as the Lloyd-Davis position. This is what we call it as the Lloyd-Davis position. It is a variation of lithotomy. Now here remember the hip flexion at the Lloyd-Davis is going to be 15 degrees, right? Along with that, there will be head down tilt also. There will be a head down with tilt of 30 degrees, right? Usually, currently, when you're talking about the Lloyd-Davis, we use for endo-uro procedures. When we talk about the endo-uro surgeries, example like TURBT, that is transurethral resection of bladder tumor, TURB, that is transurethral resection of prostate, all these can be done, right? So this is with respect to the Lloyd-Davis position, right? Now, this is a very popular position, that is a variation of supine, where you can see the head of the patient is moving downwards like this. So the head is at the downwards end, and this is what we call it as the Trendelenburg procedure. This is what we call it as the Trendelenburg. This is what we call it as the Trendelenburg position. Absolutely correct, right? What is the opposite of Trendelenburg? Where the head is now pointing upwards, the head up position, right? Now this is what we call it as a reverse Trendelenburg position. This is what we call it as a reverse Trendelenburg procedure. This is what we call it as the reverse Trendelenburg procedure or position, right? Now, what is the last image that you have? Any idea? The image number 5. Now, this is done for awake cranial surgeries, right? Now, this is what we call it as the Fowler's position. This is what we call it as a Fowler's position. The Fowler's position is done for cranial surgeries. It is performed for cranial surgery. This is position of cranial surgery, right? So this was our 15, this was 16, that is variation wala chart was 16. There is continuation of this. I hope this everybody knows. It's a very popular position where you have hyperextension of the neck, no, used for thyroid surgeries. This is what we call it as the rose position. This is what we call it as rose position, or also referred to as the barking dog position. Also referred to as the barking dog position. Either you call this as a rose position or you call it as a barking dog position, does not matter, right? The last one that you can see here, it is going to be in a semi-prone position, and this is what we call it as the Sims position. Now, how do you describe the Sims position? The Sims position is described as midway between prone and lateral. It is described as midway between. It is midway between prone and lateral position. It is midway between prone and lateral position, right? This is most commonly done when you're doing a digital rectal examination. The most common position used for this is going to be a digital rectal examination. A digital rectal exam. Here, so all these are going to be important surgical position, right? So this is with respect to all the positions that are going to be important. Got it? So that was our image number 16. Image number 17, a quick recap. Everybody knows about the surgical blades that you have. Now you have the 11 number blade, the 10 number blade, the 20 and the 22 number blade. Remember, for a precise incision, if you're looking for a precise incision, I would use a 15 number blade. If you're looking to do a stab incision, an IND or an arteriotomy, I will use a 11 number blade. For suture removal, it is 12 number blade. For all your major laparotomy as well as thoracotomy, I will use a 22 number blade. And remember, whenever you're making an incision, you'll always make the incision for the belly of the knife or the blade per se. Okay, this end is called as the belly. So always not the tip. Never put the tip. Tip se kabhi nahi hota. You have to put the belly of the blade that is present, and then you incise it. That's the best way of putting an incision. Okay. So this is with respect to surgical blade. Now going into the table, or I can say the image series 18. So far so good, guys. Okay. Now various suturing techniques that we have. So I'm going to simply name them as suturing technique A, B, C, D. The first one is what we call it as a simple continuous running suture. A simple continuous running suture. The B one is a simple interrupted suture. It's a simple interrupted suture. Now here you can see this is the suture line, and this happens to be the wound. The wound line and suture line are perpendicular to each other. So this is what we call it as the vertical mattress suture. Now if the suture line as well as the wound line are parallel to each other, this is what we call it as the horizontal mattress. This is what we call it as the horizontal mattress. Now if it does not even come onto the surface of the skin, it is in the dermo-epidermo junction of the skin, this is what we call it as the subcuticular suture. This is what we call it as the subcuticular sutures. Remember, the one with the best cosmetic outcome. The one which is going to present to you with the best cosmetic outcome. The best cosmetic outcome is going to be the subcuticular suture. It is going to be the subcuticular suture. So these are various suturing techniques that you should be aware of. Yeah. Now, what are the rules of the suturing that we follow? Now, what is the length of the suture material required? Remember, it should be minimum 4 times the length of the wound. This 4 times the length of wound. So, if the wound is 10 centimeters, the suture material to close that wound should be minimum 40 centimeters. The depth of the wound, it is going to determine the entry and the exit. Entry and the exit of the suture. It is going to determine the entry and the exit of the suture. It is going to determine the entry and the exit of the suture. The angle between the needle and the skin will remain at 90 degrees. Distance between the two sutures should be twice the depth of the, it should be twice the depth of the wound. It should be twice the depth of the wound, and the length of the suture here should be between 1 to 2 millimeters. Right? All these are important points. Yeah. So all this have been asked in an exam. They've asked you the length, they've asked you the angle between the needle and the skin has been a previous exam question, and rest of them you never know when they're going to ask, right? So be prepared. So this is one table that I would want you to remember. Now, this is again a very important set of images that you have. That is going to be the commonly used surgical instrument, right? Now, commonly used surgical instrument, they have asked you multiple times. So one second. Okay. The commonly used surgical instrument they've asked you multiple times. I want you to go through them, each individual instrument, and then quickly answer them, right? Now, the first instrument that I have shown you, or I can say the instrument number A, right? The first instrument that you can see here, you can see there is a small, this is what we call it as the mouth of the instrument. This is what we call it as the shank of the instrument. This is what we call it as the ratchet of the instrument. Right now, these are nothing but your finger holders. There's nothing about it. This is to hold your fingers. There's the shank, that is the mouth, and obviously that is joint. So here we can have, this is what we called as the joint of the instrument. So the first one that you can see here, short mouth, there are serrations which are going to be present, and this is your needle holder. Now the entire name of the needle holder is what we call it as the Mayo-Hagar. This is what we call it as the Mayo-Hagar needle holder. It is the Mayo-Hagar needle holder, right? Yeah. Now, whenever you're going to hold the needle, let's say this is how a needle is going to be presented to you. Let's say I'm giving you a semicircle needle, right? So you divide the needle into three equal parts, right? Now, this is the first one third of the needle. This is the second one third of the needle. This is the third one third of the needle. Now, where would you hold it? Now, if wherever, whichever end is the sharp edge, this is sharp edge you are going to prick it. Remember, the needle holder is going to be applied here. So you hold the needle with the needle holder between the junction of the anterior 2/3 and the posterior 1/3. So this is where the thread is going to be present, right? So from the thread, it is going to leave 1/3. Tip end is going to be 2/3. So this is going to be 2/3. So we say this end of the needle is going to occupy the 2/3, and this end of the needle will occupy the 1/3. Okay. So this is where you're going to hold the needle. This is your needle holder or the Mayo-Hagar needle holder. Now, anybody with this one? Again, a very, very important image. This is the image number B. This is what we call it. This is also a needle holder, but for a smaller needles, and this is what we call as the Castrovigi. So this is what we call it as the Castrovigi needle holder. This is what we call as the Castrovigi needle holder. Okay. Now the next instrument that you will see is this, right? So we have the instrument C here, instrument D here, right? The instrument C is also a tissue holding forceps, and this is what we call it as the Adson's tissue holding forceps. This is the Adson's tissue holding forceps. This is what we call it as the Gillies tissue holding forceps. This is what we call it as the Gillies tissue holding, a Gillies tissue holding forceps, right? How do you know the difference? You see in both of these forceps, you will have a single tooth. You can see here, this is a single tooth. Here also, you will have a single tooth. What is the difference is, the Adson's is short, the Gillies is long. So look at this, this is a short instrument, and this happens to be a long, this happens to be a long instrument, right? That's the difference between these two, right? Now, a modification of Adson's is what this one, the image number E. Now, this is what we call it as the Brown Adson's. This is what we call it as the Brown Adson's tissue forceps. This is your Brown Adson's tissue, right? Now, Brown Adson's, you have multiple serrations. They have multiple serrations which are going to be, they have an interlocking mechanism which is there. Image number F, it is an atraumatic forceps. This is what we call it as the 𝐷-𝐄𝐝 tissue forceps. All that you have to remember in 𝐷-𝐄𝐝, it is atraumatic. It does not have any tooth. It's a soft hold that you have. This is going to have a soft hold, that is your 𝐷-𝐄𝐝, right? Next you have the artery forceps that you have, or I can say the commonly used instruments. F ho gaya. This is the instrument number G. Now this is your Adson's. This is a Adson's curved artery forceps. It is your Adson's curved artery forceps, right? What is this one? Anybody? This is, you can see that tip. See, more importantly, there is no ratchet here. There's absence of ratchet. Now, if there's an absence of ratchet, remember, if you find any instrument where there's no ratchet, this is going to be our sinus forceps. This is going to be our sinus forceps. Now, if you have something which you have an interlocking mechanism, like your two hands are clasping together, it's like this. This is nothing but Alice forceps. This is going to be our Alice forceps. These are Alice forceps that you have, right? Now, to hold on to the bowel or onto the appendix, this one J. This is your Babcock, the Babcock forceps. You can see in the Babcock, this is what it matters. It's like a handcuff that you have. It's going to be like a handcuff that you're going to have it. That's your Babcock. This is the lung holding forceps. This is what we call it as the dual lung holding forceps. So you see the triangulated end. If you have the triangulated end, these are your dual lung holding forceps. These are your dual lung holding. This is instrument L. Now this is nothing but sponge holding forceps. This is your sponge holding forceps. Now usually the confusion is always between the ovum and the sponge holding forceps, right? If it is a straight one, if it is straight, it is going to be a sponge holding forceps. On the other hand, if you have a curved one, if you have a curved one, you can see it is also curving up. If it is a curved one, very good. If it is having a curved tip, this is what we call it as the ovum holding forceps. Straight one is going to be a sponge holding forceps. If it is going to be flipping, it is an ovum holding. Another very important thing, there will be no ratchet. Whereas in the sponge holding, there will be presence of ratchet. Here the ratchet is present, and here you will see the ratchet is up. That's the difference between a sponge holding forceps. That's the difference between a sponge holding forceps and an ovum holding forceps. Clear? Great. Then you have image number M. This is again a repeat exam question. It's a retractor. Everybody should know it. This is your Deva's retractor. This is your Deva's retractor, right? The other two retractors are important. I have to remember alpha and JKLM. I'll say N going to be O is N. This is going to be P. This is going to be Q. Then you have R. Then you have S. I think last one is going to be T. But then you have U also. Right. When you look at this, this is what we call it as the Langenbach retractor. A Langenbach retractor is going to be bent at 90 degrees, it will flatten end. But if you have more wider end, then this will become your Morris retractor. This is what we call it as your Morris retractor. This is going to be your Morris retractor. So Langenbach and Morris. Langenbach will have a very thinned this thing. Morris will have a more widened and more curved. So you can see in the Morris, it will have this curved appearance. It will be curved. Langenbach is going to be straight. It is going to be straight. Okay. Now this is another very famous one. On one side it looks like Langenbach but not completely bent, but the other side is like two finger forks, and this is what we call it as a Zerny retractor. This is what we call it as a Zerny retractor. So the Langenbach, and then you have the Zerny's retractor. The same thing, but if you have more curved like this, like a hand curvature like this, this is what we call it as the Doyne's retractor. This is what we call it as the Doyne's retractor. This is what we call it as the Doyne's retractor. Right? Absolutely correct. This one, anybody? This is used for your thyroid surgeries. This is your Jawl's self-retaining. It's your Jawl's self-retaining thyroid retractor. It is a Jawl's self-retaining thyroid retractor. Absolutely correct. This one, this is again a self-retaining retractor, but this is where we call it as, because it has got fingers and it claws out, this is what we call it as the mastoid self-retaining retractor. This is a mastoid self-retaining. It's a mastoid self-retaining retractor. It's going to be a mastoid self-retaining retractor. Then this is for abdominal surgeries, again self-retaining. This is what we call it as the Gallagher self-retaining retractor. This is what we call it as a Gallagher self-retaining retractor. This is your Gallagher self-retaining retractor. But a Balfour will have 4, no? This is 3 ही ना. So this is your Gallagher's. The last one that you have is your curved scissors, and these are what we call it as the Mayo curved scissors. These are actually a tissue cutting. They usually are tissue cutting scissors. Clear? Is everybody clear with this? Quick feedback. Quick feedback. Okay, can you move on? Now, somebody said, sir, Gallagher and Balfour. Because the only difference between the Gallagher and the Balfour retractor. We talk about the Gallagher and the Balfour retractor. Now, the Balfour retractor, you will have the hollow plates. So, what is a solid plate? See, this is what we call it as a solid plate. This will have a solid plate. In Balfour, you will see the plates will be like this. Right, you can see this is attached to one end of the plate, and this is how it will look like. So this is going to have a hollow right. So if it is solid plate, it is Gallagher. If it is a hollow plate, it is going to be Balfour. Is that clear? Okay. That is one thing that I can clearly tell you across. Okay. So this was about your image table number 19. We go to the next one, that is going to be 20. Now the 20th series is about common swellings. So common swellings. Okay. Can anybody identify the first image that you have? A quick feedback. The first image that is displayed across. Okay, Prajwal says sebaceous cyst. How did you know it is a sebaceous cyst? You're spot on with the diagnosis, absolutely correct. This is what we call it as the sebaceous cyst. This is what we call it as the sebaceous. This is our sebaceous cyst. But on what basis did you say it is sebaceous cyst, right? Now the most important is, obviously you can see there is a clearly demarcated swelling. So I can see the swelling which is present. The swelling can be present anywhere. But more important, with the swelling, you can see this black colored dot. This is what we call it as punctum, right? Presence of punctum in the middle. Absolutely correct, Prajwal. So there is presence of punctum. There is presence of punctum over the summit. That is the highest point of the swelling. Presence of punctum over the summit of the swelling is the indication that you're looking at sebaceous. Now, if you have a swelling which is going to look like this, that's a well-defined swelling. There is no other component which is a proxa. The skin is normal. See, another very important thing about sebaceous cyst. Now, wherever the sebaceous cyst is going to grow, the hair over the swelling is going to be lost. So remember, on a sebaceous cyst, the hair above the swelling will shed off, or I can say it is absent. So here the swelling B, as most of you have identified it correct, this is going to be lipoma. When we talk about the lipoma, it is a universal tumor. It is a universal tumor. It is benign lesion. If there are multiple lipomas, multiple lipoma with pain is what we call it as the Dercum's disease. This is what we call it as Dercum's disease. Remember, hair over the swelling. Hair over the swelling will not be lost. It is going to be present. And one of the most characteristic feature in the lipoma, it will have slip sign positive. It will have slip sign positive. Clear? Okay. That's image number B. Now, image number C is also your exam spotter. What is this image number C? Quick feedback. This is what we call it as. You can see wherever the bony plates are fusing, if you have swelling there, it is usually a dermoid, and because it is present at the angle, this will be called as the angular dermoid cyst. This is your angular dermoid cyst, right? This is your angular dermoid cyst. Absolutely correct, right? Going to the next one. Identify this one, image number 4. What is this image number 4? This is, you can see the swelling on the posterior triangle of the neck, and this is what we call it as the cystic hygroma. Now remember, the most common site is the posterior triangle of the neck. The most common site is going to be the posterior triangle of neck. Absolutely correct, right? Apart from that, remember, it is due to the sequestration. It is because of the sequestration of jugular sac. Now, one of the most characteristic features will be presence of positive trans ileum. Initially, you will try with sclerotherapy. If it fails, then you have to go with surgical excision, right? Yes, it is also associated with Turner's disease, correct, or Turner syndrome. So these are the important components about the cystic hygroma, right? Now, can you spot the image number 5? What is image number 5? Alphabet, sorry. This is image number D, number E. Okay, what is the image number E? There's a newborn baby. There is something that is coming out of the abdomen, but there's a membrane that is present on top. Now, if there is presence of membrane, then the answer here is going to be omphalo. This is going to be omphalocele. Now, if it is not covered by membrane, if the bowel is exposed, that is your image F, and this is what we call it as the gastrocele. This is what we call it as the gastrocele. Clear? Now, I've given you the whole image, how it has been reduced. Initially, bowel is exposed, you put in a bag. Now, this bag, I hope everybody knows it. Now, what is this bag called as? This is what we call it as the silo bag. Now, we fill the saline in the silo bag and gently we rotate it to reduce the content back into the abdomen. Okay? So, this is about your gastrocele, right? Yeah. So, this is going to be image number A, B, C, D, E, F, G. Now, this is a famous Bailey and Love picture also. This is what we call it as the sebaceous horn. This is a sebaceous. The last one that you have, H1, this is what we call it as the venous ulcer. Now, how did I tell you that it is a venous ulcer? Number one, look at the location in which it is found. The location around the level of ankle, this is what we call it as the gaiters area. So the first thing in favor of this is the ulcer is present in the gaiters area. It is present in gaiters area. It is present on the gaiters area. Second thing, you see that it is going to be, if this is the medial malleus, it is usually 2 to 3 centimeters above the medial malleus. So again, it is present above medial malleus. When you look at the ulcer itself, it is a shallow ulcer. It is going to have a sloping edge, and this will have a pale, scanty, unhealthy granulation. Unhealthy granule. The shallow, it is going to be, this is going to be a shallow ulcer. It is having a sloping edge. It has got a pale, scanty, unhealthy granulation tissue, right? All these points towards venous ulcer. Yeah. This is your image number H. Then your image number I. Again, your exam spotter. Now, this is your spina bifida occulta. How do you know spina bifida occulta? This is the tuft of hair. The tuft of hair which is present on the midline, and that too at the lower back. It's a spina bifida occulta. Now this, everybody knows it. It's a positive trans illumination. A positive trans illumination test. A positive trans illumination test. It is going to be present in the hydro. It is going to be positive. One, it is going to be in hydrocele. Second, it is going to be in cystic hygroma. Two tests that I would say, two sites where I'll say positive transillumination is possible. One is the hydrocele, another one is going to be cystic hygroma. Another one is going to be. So this is about all the common swellings. Clear? Clear guys, quick feedback. Quick feedback. If you want to know what are the surgeries done for hydrocele, you have two surgeries. Number one, it is going to be your Lord's procedure. Another one is going to be your Jabulois. Lords is what we call it as the sac plication. The Lords is what we call it as the sac plication, and Jabulois is what we call it as sac eversion. The Jabulois is what we call it as sac eversion, right? Yeah, intraoral swellings, we have ranula and plunging ranulas. Yes, that is another image to be concentrated upon. Yeah, guys. So far, good. So this completes your entire discussion on your common swellings that you have. Okay? Clear? Sorted? Yeah. Okay? So we'll start with the systemic part now. So there are a lot of images in the systemic part. Let's do it this way. We'll take a short break here for 10 minutes and then we'll resume back with the systemic part. So we finish the general surgery images. We'll start with the systemic one, take a 10 minutes break and we'll resume back, right? We'll just mention it. A 10-minute break. We resume back at 7:40. We resume back at 7:40. All right, guys, let's set out. Can we continue? Can we continue? Quick feedback. Right. So we'll talk about the systemic part of the surgery now. Yeah. Now, in traumatic head injuries, you have two images that you will see. The number one is EDH, the other one is SDH. In extradural hemorrhage, as you see, this is the opacity we are able to see. Now, this is what we call it as the biconvex opacity. This is what we call it as the biconvex opacity, or also called as the lenticular opacity. It is the lenticular opacity. In EDH, the most common source of bleeding, the most common source of bleeding is going to be the middle meningeal artery. Correct. This is going to be our middle meningeal artery. Here is the middle meningeal. It is the middle meningeal artery. Right. Now, remember in the extradural hemorrhage, mannitol is contraindicated because if you give mannitol, the brain will further shrink, causing again extensive hemorrhage. Another very important thing about EDH is presence of lucid interval. Presence of lucid interval. And I hope everybody knows the EDH investigation of choice is going to be NCCT, and the management for EDH is going to be craniotomy. It is craniotomy. Correct. Right. Now coming to your subdural hemorrhage, you see in the subdural hemorrhage, this is how the hematoma is going to look like, or the collection is going to look like in this way, right? So here we say in a subdural hemorrhage, it is going to be concavo. Sorry. Okay. This is your concavo convex opacity. This is a concavo convex opacity, or also commonly referred to as the crescent opacity. It is a crescent opacity. The most common source of bleeding here is going to be the cortical bridging. It is the cortical bridging vein, right? So talk about the characteristic feature. You will say there is presence of pupil dilation. So pupil dilation with will be progressive. Investigational choice here is going to be NCCT. For large subdural hemorrhage, we do craniotomy. For chronic SDH, for chronic subdural hemorrhage, you can do a burr hole. For a chronic subdural hemorrhage, you can do a burr hole. So these are with respect to EDH as well as SDH, right? Now, let's say any patient who has presented with trauma, a post-trauma, if the patient lands up with coma, and if the NCCT of this patient is absolutely normal. Now, this is what we call it as the diffuse axonal injury. This is what we call it as a diffuse axonal injury. As most of you know, in diffuse axonal injury, there's complete disruption of axons between the white matter and the gray matter. When you look here, the GCS is going to be absolutely poor. CT is normal, but when you get an MRI done, as you have the image here, on an MRI, there will be presence of punctate hemorrhage. There is presence of punctate hemorrhage between white and gray matter. Between white and gray matter, which you can see. All this are your punctate hemorrhages. Same here, you can see. Presence of punctate hemorrhage between the white and the gray matter is what we say that is associated with a diffuse axonal injury. Remember, it is associated with very poor prognosis. It is associated with very poor prognosis, right? Now, radiology spotters, again, this will be dealt in your radiology again, so we'll quickly go through it. So this was, I forgot to label it. I think this is 20, so this is going to be 21, right? So this was our image set number 21. This was the set number 21 that you have. Now here you have set number 22, right? So in set 22, you have all the esophageal spotters, right? Now the first spotter that you can see here, it's a child where there's a coiling of nasogastric tube, right? So if you have a newborn, this newborn is presented with repeated episodes of regurgitation. There is repeated episodes of regurgitation. Repeated episodes of regurgitation on day 0 and day 1. And when you do a radiograph, there is coiling of nasogastric tube. Then this is a diagnosis of tracheoesophageal fistula. Remember, the most common type of tracheoesophageal fistula is going to be type C. And the investigation of choice here is going to be the contrast imaging. The investigation of choice here is going to be contrast imaging. Now, when you do a contrast imaging, the safest contrast that you are going to use is going to be iohexol, which is an iodinated contrast. Iohexol is an iodinated contrast. So it's a newborn. The coiling of nasogastric tube, the most common type is going to be type C variety, and the investigation of choice is going to be iohexol induced contrast imaging. That's the important objective. Now here you can see that there is a mucosal narrowing on a barium swallow. Now this mucosal narrowing on a barium swallow is what we call it as the upper esophageal web. This is what we call it as the upper esophageal web. Now this upper esophageal web is associated with Plummer-Vinson syndrome. This is associated with Plummer-Vinson. So when we say the Plummer-Vinson syndrome, what are the components of the Plummer-Vinson? So what do you see in Plummer-Vinson syndrome? Number one is iron deficiency anemia. Number two, there is atrophic glossitis. It is atrophic glossitis. Presence of upper esophageal web. This presence of upper esophageal web associated with koinonchia as well as visceromegaly. Now, Plummer-Vinson syndrome increases the risk for esophageal cancer. When we talk about Plummer-Vinson syndrome, it increases the risk for squamous cell cancer of esophagus. It increases the risk for squamous cell cancer of the esophagus. Right, that is about your upper esophageal web. Now you see, this is now in the lower esophageal. There is again a mucosal narrowing on the either side. This is your lower esophageal web. Now, when you see this is as the lower esophageal web, now this lower esophageal web, it is secondary to GRD. It is secondary to the GRD. Now, can anybody tell me the name of this? This is usually secondary to GRD. Can you tell me the name? This lower esophageal web, it is secondary to GRD, and this is what we call it as the Schatzki. This is what we call it as the Schatzki finger. This is nothing but your mucosal synechium. These are nothing but your mucosal signicae. One second. Okay. These are nothing but your mucosal adhesions. So because of mucosal adhesion due to due to GRD. Okay. The next one that you can see here is again a very classical image of a barium swallow, right? So everybody, these are all three of them are barium swallow, so nothing spectacular about it. Can you identify the image shown in the barium swallow? It looks like an apple. Somebody has eaten the apple and left the core behind. So this is what we call it as the apple core sign. This is what we call it as the apple core sign. Now, when you look at this point, it's as if somebody is shrugging the shoulders here. So this is also called as the shouldering sign. This is also referred to as the shouldering sign. So apple core sign or a shouldering sign basically indicates a mass. So this is your esophageal cancer. This is your esophageal carcinoma. Then comes here again an interesting image. Now this is the anterior surface, this is the posterior surface. You can see this is the cervical vertebra. So in the cervical region, you see on the posterior surface there is an outpouching which is present. So this is your cervical esophageal diverticulum. Your cervical esophageal diverticulum. This is your cervical esophageal diverticulum. As most of you have rightly pointed out, this is nothing but your Zenker's diverticulum. This is nothing but your Zenker's diverticulum. Now, couple of important questions about the Zenker's diverticulum. Can anybody tell me that where do you find or what is the anatomical weakness for the Zenker's diverticulum? Now remember the anatomical weakness. When you look at his Zenker's diverticulum, yeah, you guys are a bit ahead of me. You're giving me answers, but spot on here. When you talk about the Zenker's diverticulum, number one, it presents on the posterolateral surface, which is usually on the left side. Yes, so this is going to be from the Killian's dehiscence or the Killian's triangle, right? The Killian's triangle, I hope everybody knows it. For a quick recap, if you take this as the representation of the hyoid bone that you have, this happens to be the thyroid cartilage, this happens to be the cricoid cartilage, this happens to be the trachea. These are your tracheal rings which are present. Now let's say this is the hyothyroid membrane, this is your thyrocricoid membrane which is present. Behind this you have the esophagus which is running, and this is where you have the esophageal component. Now this is the esophageal muscular wall, the outer longitudinal muscles which are running across here. The two muscles which are going to be present, the obliquely placed thyropharyngeus muscle and transversely placed cricopharyngeus muscle. Now, between these two sets of muscle, your obliquely placed thyropharyngeus muscle and your transversely placed cricopharyngeus muscle, you see this triangular area which is not guarded by any muscle. This is what we call it as your Killian's dehiscence or the Killian's triangle. This is what we call as Killian's dehiscence, the Killian's triangle. Now, second thing, Zenker's diverticulum is an example of a false diverticulum. It is an example of a false diverticulum, right? Number three, it is there are two varieties, pulsion or tractional diverticulum. This is an example of a pulsion diverticulum. This is an example of pulsion diverticulum. This, whenever the dysphagia, whenever the patient of Zenker's diverticulum is going to present to you, they'll present to you with number one, regurgitation. There is regurgitation of previous day food particle, previous day food particle with halitosis, with intermittent dysphagia, with intermittent dysphagia is going to present. Here the investigation of choice is going to be the barium. It is going to be barium swallow. Management is going to be surgery. If it is more than 3 centimeter width, then you have the endoscopic Dolman surgery. If it is less than 3 centimeters, then you have to do a diverticulum. then you have to perform diverticulectomy, right? So this is with respect to Zenker's diverticulum. This is with respect to Zenker's diverticulum, right? Now, another spotter that you have, it's a newborn baby. It is newborn on day 0 of life. What do you see? You see a massive air bubble in the left hem. This is the right side, this is the left side. So you have the massive air bubble in left hemithorax. You see the mediastinum shifted onto the other side. So this is your dextrocardia. There is this dextro. So there's massive air bubble in the left hemithorax. There is dextrocardia, and the baby will have respiratory distress at birth. So this is a classical image of Bostalic hernia. This is a classical image of the Bostalic. Now remember, it is the most common congenital hernia. It is the most common congenital diaphragmatic hernia. It is the most common congenital diaphragmatic. It accounts for 90% of the total diaphragmatic hernia. Now the defect in the Bostalic hernia, it is going to be left-sided. It is a left-sided posterolateral defect. It is a left-sided posterolateral defect. The most common organ to herniate. The most common organ to herniate. It is going to be stomach. In the Bostalic hernia, the most common cause of death. The most common cause of death in a Bostalic hernia, it is pulmonary hypoplasia. It is pulmonary hypoplasia. It is a pulmonary hypoplasia. But not necessarily always it is going to be loops. Sometimes you can have this stomach. See, most common is stomach. If it is a small bowel, then you'll have more of loops. Okay. So it's the most common congenital diaphragmatic hernia. Defect is left-sided posterolateral. Most common organ to herniate is stomach. The most common cause of death is going to be pulmonary hypoplasia. And the triad of the Bostalic hernia that you will see is RDS, that is your respiratory distress. There is dextrocardia. And there is scaphoid abdomen. And there is scaphoid abdomen. This scaphoid abdomen, right? So this is with respect to all the important points with respect to Bostalic hernia. Yeah. Another point that I can add on here is, remember, the bag and mask ventilation is contraindicated. The bag and mask ventilation is contraindicated because it is going to overinflate the stomach, worsening the respiratory distress. Okay. So these are the first set of spotters that you have. This is another spotter on an upper GI endoscopy. So when you do an upper GI endoscopy in an esophagus, this is what we call as presence of red velvety mucosa. A presence of red velvety mucosa basically tells you that it is your Barrett's esophagus. This is your Barrett's esophagus. Now, when it comes down to Barrett's esophagus, now in terms of Barrett's esophagus, it is intestinal type of metaplasia. It is an intestinal type of metaplasia. We call it as an intestinal type of metaplasia because it will have columnar epithelium with presence of goblet cells which produce mucin. Barrett's esophagus increases the risk for adenocarcinoma of the esophagus. It increases the risk for adenocarcinoma of esophagus. Right? Now, when we say a classical Barrett's is defined as more than 3 centimeter of this red velvety mucosa. Of this red velvety, yeah, correct. So, yeah, you have, we call it as the 4-sectional biopsy or 4-quadrant biopsy. All those extra details we'll talk it when you talk about a quick rapid revision. Okay. But now on the image basis, this is what you have to recall. All that you have to remember with respect to Barrett's esophagus. Spot on, guys. Okay. So now this is our table number. This is 22. This is 23. Now here it's about the neonatal vomiting. We'll see how they are presented, on which day they are presented, and how we are going to talk about it. If a baby is 4 weeks old and the baby presents to you with non-bilious vomiting, it is going to be non-bilious vomiting, and this is going to be projectile in nature. And when you do an imaging, you can see there's presence of single bubble sign. There's presence of single bubble sign. Now you know the diagnosis. What is the diagnosis? Yes. Now here it is going to be, I'll just put a triangle. It is going to be congenital hypertrophic pyloric stenosis, also called as idiopathic hypertrophic pyloric stenosis. Either you call it as CHPS or IHPS, does not matter. It is congenital hypertrophic pyloric stenosis or idiopathic hypertensive pyloric stenosis. Now remember, the management here is going to be surgery, and the surgery of choice is going to be your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. Now, the additional question that they can ask you here is the most common electrolyte, imbalance. Now, the most common electrolyte imbalance that you can see here, that is, now because of an excessive vomiting, the patient is going to lose the gastric content, which is rich in hydrochloride, that is the acid, along with water, along with sodium. So loss of chlorine will result in hypochloremia. There's hypochloremia. Excessive proton loss will result in metabolic alkalosis. There is metabolic alkalosis. To compensate, the RAS system is going to kick in, which will cause excessive loss of potassium. There is hypokalemia. Along with that, there is paradoxical acid. If there is a delayed presentation, the compensation of sodium will go. So they'll also have hyponatremia. Right? Remember, whenever you're talking about the management CHPS, the first line of management in CHPS, it is electrolyte correction. It is the electrolyte correction, and the most important electrolyte to be corrected is chloride. So it is the chloride correction which is more important when compared to potassium. It is the chloride correction is more important when compared to potassium, right? That is what you have to remember with respect to your CHPS, right? Coming down to the next case, I have day 0, day 1. This time, let's say I have a patient who is presented to me with a bilious vomiting, which is non-projectile. Uh, this time I can say I have 2 bubbles, that is your gastric bubble. I have the gastric bubble and the duodenal bubble. So this is what we call it as the double bubble sign. This is what we call it as the double bubble sign. So I hope everybody knows the double bubble sign here indicates duodenal atresia. It indicates there is duodenal atresia. Now, to confuse you, they can add another one. Same day 0, day 1. The patient here can have both bilious or non-bilious vomiting. It can have both bilious, non-bilious. This is also usually non-projectile. This is also non-projectile. Okay. Rather than, okay, let's not have any confusion. Here the patient is having bilious vomiting, again non-projectile. But when you go ahead with the imaging, you can see this is the gastric bubble, this is a duodenal bubble, this is a jejunal bubble. So I have three bubbles here. I have three bubbles here. This I would call it as the triple bubble. This is your triple bubble sign, right? A double bubble sign can be of duodenal atresia, or it can be seen in your annular pancreas. It can be seen in your annular pancreas. That is why the investigation of choice is going to be the CCT abdomen. Management here is going to be duodenostomy, even though it's an atresia or annular pancreas. Here it is triple bubble sign that indicates it is jejunal atresia. The jejunal atresia. The investigation choice here is also going to be the abdomen. Management is going to be jejuno. Is going to be jejunostomy. Here. So this is with respect to your neonatal vomiting. Again, very, very important. I should have put a heading here. So this is about neonatal vomiting. So if you have the babies coming down to you with neonatal vomiting, this is how we are going to address. Yeah, got it? So continuing on the same imaging series, what is this? Again, all these are spotters. We'll quickly run through them. This is what we call it as the feline esophagus, also known as the stacked mucosal ring, also known as stacked mucosal rings. And we all know this is seen in eosinophilic esophagitis. This is seen in eosinophilic esophagitis, and it can also be associated with GERD. So two conditions where you have a feline esophagus. Number one is going to be eosinophilic esophagitis, another one is going to be GERD. Now the second one is going to be foreign body that is going to be present. So if there is presence of foreign body, if there is presence of foreign body and you get an X-ray done, let's say you get an X-ray which is going to be, let's say, an AP view. In an AP view, if you see the entire face of the coin, it is what we call it as N face. If the coin is present as N face in AP view, then it is going to be in esophagus. Then it is going to be in esophagus. But if you have X-ray which is on a lateral view, you have a lateral view. On a lateral view, if there is N face, then the foreign body is in trachea. Then I can say that the foreign body is going to be in trachea. Then the foreign body is going to be in trachea. Okay. So if it is an AP view, if it is on an AP view, N face, it is esophagus. If it is on a lateral view, it is going to be trachea. So here we have an AP view. I have N face presentation of coin. N face means the entire face is visible. So hence this is going to be in esophagus. Now if you observe very carefully, the same foreign body, you will have a rim sign or absence of rim sign. So if you look at the first one, this is the image number one, this is the image number two. In the image number one, you can see there is one border which is here, and then you can see there's a border which is encirculating here. So this is what we call it as presence of rim sign. If the rim sign is there, that indicates this is your button battery. Now button battery are emergencies because they are going to produce alkali. So we have acid, we have alkali burns. Now this is going to produce alkali, which is going to cause liquefactor necrosis, so more dangerous. If there is no rim sign, this is your coin. In coin, there will be absence of rim sign. In button battery, there will be presence of rim sign. That is what you have to remember. with respect to the foreign body. Now, if you have a presentation where you have a male child, it's a male child, 4 weeks old, with recurrent episodes of non-bilious vomiting. A recurrent episodes of non-bilious vomiting. For this, the investigation of choice is going to be ultrasound. So when you do an ultrasound, you will see that there is this thickening which is going to be present. If this thickening is around 4 millimeters and the length of the thickening is more than or equal to 16 millimeters. If the length is more than or equal to 16 millimeters and if the width is more than or equal to 4 millimeters, this is going to be a congenital hypertrophic pyloric stenosis. So this is what we call as the antral nipple sign, right? This is what we call it as the antral nipple sign. So on an ultrasound, you'll see the length of the thickness is more than or equal to 16 millimeters. The width of the thickening tract is more than or equal to 4 millimeters. Now this concludes the patient is having congenital hypertrophic pyloric stenosis, right? Now when you do an ultrasound, this is what we call it as presence of the antral nipple sign. So when you do a barium swallow or the barium meal per se, here you will see double track sign. There will be a double track sign or also called as the mushroom sign, right? All the what we have dealt with already more amount of data with CHPS, but this is the USG image of the CHPS that you should be aware of. Okay? So this is on the contrast imaging that you are going to talk about it. This is what we call it as the double track sign. This is your double track sign. Along with the double track sign, this is also called as your mushroom, also referred to as the mushroom sign, right? Now this is again a spotter. Now you can see this happens to be the diaphragm on the right side. This is the left side. This is the liver shadow and there's a free air under right hemidiaphragm, right? Now this is nothing but your hollow viscous perforation. This is your hollow viscous perforation. Now in a hollow viscous perforation, you have free gas under right hemidiaphragm. This is your free gas under right hemidiaphragm, right? Now, usually it can be seen in peptic ulcer disease, which is usually we have the duodenal ulcers which are going to perforate. You will do a Graham's or mental patching. Now, same hollow viscous perforation where you have more amount of air is going to get trapped. In the hollow viscous perforation, the other two signs that you can see, the hollow viscous perforation, the other two signs that you will see is going to be a dome sign and a regular sign. The other sign that you see is a dome sign. Now, in a dome sign, the entire abdomen is filled up with air. So, in the periphery, if you look at here, the entire periphery will have a rim of air shadow. It's look like a dome. So, this is what we got as dome sign. Second is going to be your regular sign. Now, what is this regular sign is? In a regular sign, the bowel wall will become clearly delineated. You can see this bowel wall is clearly delineated. Now, what happens is normally if this is the bowel which is present, if the air is present inside, you will be able to see the air as an air shadow. Here in hollow viscous, the air is present outside also. So, between the two air shadows, you can see a rim of bowel, and that is what we call it as a regular sign positive. So if you are able to see the wall, that is the bowel wall, we call it as a regular sign positive. Now this is quite interesting. You have ABC as three components on a CT image. I will just label them as A, B and C. This is A, this is B and this is C. A, there appears to be presence of a stone because of calcification. We call it as ectopic stones are present. Now B, you can see it is all blocking the stool, so there is presence of bowel obstruction. There is presence of bowel obstruction. See, there is air in the biliary system, so there is pneumobilia. So ectopic stones with bowel obstruction with pneumobilia is what we see classically in gallstone ileus. This is what we see in gallstone ileus, and this is what we call it as the Rigler's triad. This is what we call it as the Rigler's triad. So ectopic stones, bowel obstruction, as well as pneumobilia is present. Now the most common cause for this, is bilioenteric fistula. It is the bilioenteric fistula. Now if I say what is the most common site for this fistula, is it your cholecystoduodenal. It is cholecystoduodenal, right? That's about your gallstone ileus, right? Okay, moving on. This one we have already dealt with this. It's a newborn baby. So day 0 or day 1 of life, repeated episodes of bilious vomiting, and you can see that two bubbles. One is your gastric, another is duodenal. So on an X-ray, there is double bubble sign. On an X-ray, there is a double bubble sign. So whenever you have a double bubble sign, it basically means it can be of two varieties. Either it's a duodenal atresia, or it could be the other one, that is your annular pancreas, or it is going to be the annular, as simple as that. Okay. Now here you can see multiple air fluid levels in a step ladder pattern. So presence of multiple air fluid, there's multiple air fluid levels presence in a step ladder pattern. Now these two indicate small bowel obstruction. These are small bowel obstruction. Remember, normally there are 2 to 3 air fluid levels. There are normally 2 to 3 air fluid levels. If there are more than 3 air fluid levels, then it is going to be associated with small bowel obstruction. Now here you can see the hair in the stomach, and this is what we call it as the trichobezoar. The trichobezoar. Now, when you talk about trichobezoar, what is the other name for trichobezoar? Quick feedback. Other name for trichobezoar. The other name for trichobezoar is also referred to as the Rapunzel syndrome. Also referred to as the Rapunzel syndrome. In a psychiatric disorder, it is associated with trichotillomania, where a patient plucks the hair and eats it, right? That's a Rapunzel syndrome. Absolutely correct, right? Now, what is this spotter? Any idea? Quick feedback. This is your thumbprint sign. This is your thumbprint sign that is your associated with. Where do you see thumbprint sign? Thumbprint sign. The thumbprint sign is basically associated with ischemic status of the bowel, and that is your ischemic colitis. It is seen in ischemic colitis. It is seen in ischemic colitis, right? Now, another spotter that you have, same, you have multiple bowel loops, presence of multiple bowel loops in left hemithorax. Left hemithorax in a newborn, then the answer here is going to be your Bosch-Talek. Going to be Bosch-Talek horn. In the colon, you can see an apple core sign. So when you do a colon imaging, in a colon, there's presence of apple core sign. The apple core sign in colon is indicative of colon cancer. It is associated with colon cancer. Then you see another image which is quite extensive here. The contrast is stopping here. It looks like a claw sign, and this is what we call it as. On a contrast, there is presence of claw sign. A claw sign on the contrast image is basically a presentation of intersusception. When we talk about intersusception, remember it is more commonly seen in children when compared to adult. When compared to adult. The most common site of intersusception in children, it is going to be ileo. The most common site in adult. The most common site in adult is going to be colocolic. Now, in a neonate, or I can say in a child less than 1 year, there will be presence of red currant. Presence of red currant jelly stools in an intersusception indicates resolution. It basically indicates resolution, so everybody knows it. See? Okay. Now, a technetium 99 in an abdomen, what do you see? If you do a technetium 99 scan in the abdomen, there's presence of an ectopic foci. Presence of ectopic foci on a technetium 99 in an abdomen is characteristic of Meckel's diverticulum. It's a characteristic of Meckel's diverticulum. Now, as it is usually asked, what type of diverticulum it is, right? Number one, it is an example of a true diverticulum. An example of a true diverticulum. It's a congenital diverticulum. It is a congenital diverticulum. It arises on the antimesenteric surface. So it's an antimesenteric diverticulum. It is an antimesenteric diverticulum, and it follows something called as the rule of two. Now, in it, rule of two, everybody knows it. It is going to be 2-inch size. It is going to be 2 feet. When I say 2 feet, approximately 60 centimeters, proximal to IC junction. Proximal to IC is 2 feet, proximal to IC junction. It's 2 inches in size, 2 feet proximal to IC junction. It has got two different mucosa. It has got two different mucosa, and it is seen in 2% of the population. This is the most common congenital disorder of the intestine. The most common congenital disorder of the intestine, right? That's about your Meckel's diverticulum. Now, another image that you will see is here on an classical X-ray. This is what we call as a classical coffee beans. This is what we call as the coffee bean. So far so good, guys. Quick feedback on the chat box. Now, when I say a coffee bean sign, I hope everybody knows it is associated with volvulus. It is associated with volvulus, where a loop of intestine rotates around its own axis, right? Now, when it comes down to volvulus, now you have to understand where exactly the volvulus is pointing. Now, if you take this as the abdomen, this is the right upper abdomen, this is the left upper abdomen. If the volvulus is pointing towards the right upper abdomen, the origin is going to be your sigmoid colon. But if it is pointing on the opposite direction, if it is pointing in the left upper abdomen, then it is going to be the cecal volvulus. Then it is going to be your cecal volvulus. So if the coffee bean is pointing towards the right upper abdomen, it is your sigmoid volvulus. So if the volvulus, I can put it here. If the volvulus, if the coffee bean is pointing towards right upper abdomen, or the coffee bean is pointing at the left upper abdomen. If it is pointing toward the right upper abdomen, then it is going to be your sigmoid volvulus. If it is going to be in the left upper abdomen, if it is going to be left upper abdomen, then it is going to be your cecal volvulus. It is going to be your cecal volvulus, right? So this is what you have on the volvulus. The same thing on a volvulus. If you do a contrast imaging, this is as if a bird is waiting to catch its prey, and this is what we call it as the bird of prey sign. If you have the bird of prey sign, the bird of prey sign, it is also seen in barium enema. If you do it on sigmoid volvulus, we're doing on a sigmoid volvulus. Can you see this image again? A spotter. This is your sawtooth appearance. Sawtooth appearance on a barium enema. If there is a sawtooth appearance on barium, if there is a sawtooth appearance on a barium enema, this is going to be associated with diverticulum. This is associated with diverticulum. Sawtooth appearance on a barium enema is associated with diverticulum. Yep. So this is your the entire set of GIT. So far, any doubts, guys? Quick feedbacks. Achha, what is the classification for diverticulitis? Classification for diverticulitis. This is going to be your classification. This is going to be the classification. Correct. Yeah, guys. Yeah. So, can you move on? So this is about your the GIT one. Give me 1 second. The app is getting updated. Second. 1 second. Okay, just wait for 10 seconds. It's just getting updated. Almost there. Okay, I think we're there. So we have the uroradiology. Okay, so let's quickly going through them. Now the first spotter, you can see this is what we call it as the flower vase appearance. This is what we call it as the flower vase. And the flower vase appearance is seen in horseshoe kidney. It is seen in horseshoe. Now, in the horseshoe kidney, the question that they ask you is, number one, what is the level of the isthmus of the horseshoe kidney? It is between the third and the fourth lumbar vertebra, right? Which prevents the ascent of horseshoe kidney. The ascent of horseshoe kidney is prevented by the ascent of the horseshoe kidney is prevented by, it is the inferior mesenteric artery. It is the inferior mesenteric artery. Absolutely correct, right? Okay. What is the indication? What is the indication to divide isthmus of horseshoe kidney? What is the indication to divide the isthmus of the horseshoe kidney? In fact, there is only one indication where you would divide the isthmus of the horseshoe kidney. There is only one indication, and that is if you are going with abdominal, if you are going with abdominal aortic aneurysm. You're doing an abdominal aortic aneurysmal repair, and that's the only indication to do a division of isthmus of the horseshoe kidney. The second one, you can see there is a calcification which is taking the entire shape of the pelvic calcium system, and this is what we call it as the stag horn calculi. Now, this stag horn calculi is also called as the struvite. It's called as the struvite stone. This is also referred to as the triple stone, also called as the triple stone. So this is caused by infection, and the most common organism is also called as the silent stone also. Now, the most common organism responsible for creating this havoc is your Proteus infection. It is your Proteus bacteria. Now, this is associated with the worst prognosis. This is associated with the worst prognosis among all the other stones. Then you see the image number 3. So if I say this is the image number 1, this happens to be the image number 2. In the image number 3, it is more like a mushed up. You can see the kidney is calcified, but it is all mushed up kidney, and this is what we call it as the putty kidney. This is what we call it as the putty kidney. The putty kidney is seen in renal tuberculosis. It is seen in renal tuberculosis, right? Now, this is again a very classical image where you see the ureter is traveling in this fashion. So originally when you try to place it, you will see the inferior vena cava is going to run across here. So this is the IVC which is running, and you see this is the ureter. The ureter is originating from here. It is going behind the IVC. It is coming in front of the IVC and running it. And it goes and opens onto the bladder. Right? You see, it is like a fish hook ureter. Right? Now, this fish hook ureter is nothing but your retrocaval IVC. Right? It's a retrocaval ureter. So this is what we call it as a fish hook ureter. Now, this fish hook ureter is because ureter is going behind the IVC. So it is a retrocaval ureter. Right? This can produce with hydronephrosis, as simple as that. Right? The fish hook ureter which is present. Now, this is what we call it as the soap bubble sign. This is what we call it as the soap bubble sign seen in hydronephrosis. Seen in hydronephrosis. It's a soap bubble sign seen in the hydronephrosis. I no, the voice has to be fine better. If the voice is low, probably it is some issue at your end. Kindly check it. I'm just checking. Voice is perfect, beta. I'm checking on my phone as well. The voice is absolutely fine. Now here you can see if you have a kidney which is presented here. Let's say this is the representation of the kidney, and this was supposed to be the pelvic calcial system which is present. Now you see the pelvic calcium system is completely thinned out like this, right? This is like a spider leg appearance, right? So if you have a patient with a bilateral spider leg appearance, bilateral spider leg appearance, it is seen in polycystic kidney disease because your polycystic kidney disease are always bilateral. Polycystic kidney disease is always going to be bilateral, right? Now, any patient of PKD, what is the surgery of choice to reduce symptoms, or I can say to relieve of pain, to reduce pain in PKD? And the answer is going to be Rovsing surgery. What is the surgery of choice? It is going to be renal transplant. The most common cause of death in a patient of polycystic kidney disease is your hypertensive complication. It is your hypertensive complication. It is your hypertensive complication. Right? That's about your polycystic kidney. Right now, this you can see the adder head appearance is here. Like on the behind the cobra's head, you will see the appearance and the adder head sign. The adder head sign is seen in uretro-C. It is seen in uretro-C. It is going to be seen in uretro-C. Yeah. Yeah. Today something is wrong with the YouTube. I'm not able to access the chat box as simply as it used to be. Some issues are going on. Okay. Anyhow. So this is about your radiographs. Now these are the Foley's catheter. We have already dealt with most of them. The first one is what we call it as the standard Foley's catheter. The second one is your three-way Foley's catheter. If you change the material for longer duration, we have the silicon Foley's catheter. And sometimes if there is a urethral stricture or a BPH, you need to use a curved tip one. So if you have a curved tip Foley's catheter, if there is a curved tip Foley's catheter, this is what we call it as the chordae. This is what we call it as the chordae Foley's catheter. A chordae Foley's catheter, tip of the Foley's catheter. This is used when there is any urethral stricture or in BPH where the you're not able to pass a regular Foley's catheter, right? Now, when you look at the color code and the size, so the mnemonic that you remember is GORY is very beautiful. GORY, GORY is very beautiful, right? G stands for green. G stands for green color. O stands for orange. Red is the R is your red. Y happens to be yellow. B happens to be violet, and B happens to be blue. So look at the size of in French that we talk about it. So when we talk about the green color one is going to be a 14 French, orange is 16 French, red is 18 French, yellow is 20 French, violet is 22 French, blue is going to be 24 French. So blue is going to be 24 French, right? Now, when you look across here, what is this French basically means is whenever you take a tube, let's say you take a catheter or any form of catheter, let's say this is the tube that you're talking about. Now, this tube will have two diameters, right? The inner diameter and the outer diameter of the tube. Now, this is what we call it as the inner diameter. So, DI is the inner diameter and this happens to be the outer diameter, that is DO. Now, the outer diameter of the tube is what we call it as the French relates to the outer diameter of the tube. The outer diameter of the tube is what we call it as the French, right? Another spotter that you can see here, this is what we call it as the DJ stent or a double J. Now, this is used whenever using any urethral surgery to keep it ureter patent. This is what you're going to put it as double J stent. This is what we call it as the Dormia basket. Now, the Dormia basket is used for stone extraction. The Dormia basket is used for the stone extraction. This is used for stone extraction, right? Next, you have the urethral injury. Let's say decode both the image number 1 and the image number 2. Now, in the image number 1, now in order to understand both the images, you need to understand this is going to be blood. From here, you have the prosthetic urethra. The prosthetic urethra will continue into membranous urethra, which is the thinnest one. Then you have the bulbar urethra. You'll have a nice hunch like this. And the last one you will have is the penile urethra. So whenever the contrast is going to pass, you will see you have to identify this hairpin loop, right? Wherever you see this hairpin loop is present, this is your bulbar urethra. After that, this is going to be penile urethra. Before it, it is going to be the membranous urethra and the prosthetic urethra. Now you can see the contrast here. It is entering. It goes here. Before the hairpin loop even completes, it starts leaking. So the leak is from the bulbar urethra. So this is your anterior urethral injury. This is your anterior urethral. Now here in the image number 2, I am able to see the penile urethra. This is the hairpin loop, the bulbar urethra, and then the leak occurs after this. So that means it is on the posterior urethra, that is on your membranous urethra. So this is your posterior urethral injury. It's a posterior urethral injury. Yeah. Is everybody clear how to identify the anterior and the posterior urethral injury? Because that's one of the most frequently or repeatedly asked exam questions. The radiographs clear? Quick feedback. Anterior and the posterior urethral injuries. Can we move on? Sure. So another image that you will see in the urology is this. This is what we call it as the Fournier's gangrene. This is what we call it as the Fournier's gangrene. So when you say Fournier's gangrene, this is described as the necrotizing fasciitis. It is a necrotizing fasciitis. It is a necrotizing fasciitis of perineal region. It is a necrotizing fasciitis of the perineal region. It is going to involve both aerobic as well as anaerobic infection. Right. Now remember, the usual risk factors here are going to be diabetes and the immunocompromised status. The immunocompromised state, right? Uh, Here the management is going to be IV antibiotics with debridement. Now, as an important note point, remember testes are spared. In Fournier's gangrene, testes are not touched; they are spared. So this is also called as shameless testes, no? Because the testes are getting exposed. Yeah. So this is about your Fournier's gangrene. So far, so good. So this concludes your uro images as well, right? So going on to the last set, that is your hepatobiliary and pancreatic image. Right. Now in the image number 1, you can see here, this is the gallbladder. There's a air which is present and the fluid level that is present. So in the peripheral rim, you can see there is this air which is present. This is the classical fluid level that is present. So there is air with the air fluid level, right? So this is what is nothing but the emphysema gallbladder. We call this as the emphysematous gallbladder. It is the emphysematous gall. Now, look at this image. Now, in this image, you can see that there are multiple uh, outpouchings which are present, and this is what we call it as the gallbladder diverticulosis, right? This is what we call it as the diverticulosis of gallbladder. This is what we call as the diverticulosis of the gallbladder. Right. Again, this is an indication, or this increase the risk for chronic cholecystitis. It increases the risk for chronic cholecystitis. Right. Right. This you can see pneumobilia, air in the biliary system. When I say there is air in the biliary system, the presence of pneumo, here there is presence of pneumobilia. So air in the biliary system is an indication of biliary. This is an indication of bilioenteric fistula. We have already discussed about the gallstone ileus. Okay? Now this is where you have a free floating membrane in a liver that is on a CT. This is classical for your high dated. In a high dated cyst, there is a free floating membrane. There is this free floating membrane that is present. Now here you can see there is a central scar which is present. Now a central stellate scar is seen in focal nodular hyperplasia. So this is your central stellate scar. Now this central stellate scar is seen in focal nodular hyperplasia. It is seen in focal nodular hyperplasia. This is also seen in serous cyst adenoma of pancreas. It is seen in focal nodular hyperplasia, serous adenoma of pancreas, fibrolamellar, the fibrolamellar variant, the fibrolamellar variant of hepatocellular carcinoma and renal oncocytoma. In a renal oncocytoma, right? All these are going to have a central stellate scar-like appearance, right? Again, an important image from our exam perspective. Now, previously in our exam, they did ask you about the hydrated cyst, which was an image-based question. Now, this is also your previous exam question. They've asked you how do you differentiate between a gallstone and a gallbladder polyp. So, I have the image A and the image B. Now, in an image A, I can see that there is a shadow which is present. So, this indicates is a lesion. But what follows here, you can see in the image number B, you have the post-echogenic shadow, but here it is not available. So, if the post-echogenic shadow is absent, this is going to be a gallbladder polyp. In a gallbladder polyp, post-echogenic shadow is absent. Post-echogenic shadow is absent. In B, it is your gallstones. In gallstone, there is post-echogenic shadow is present. Post-echogenic shadow is present. Okay. Next one, the image is strawberry gallbladder. This is an example of cholesterosis, but remember strawberry gallbladder. You can see this is your comet tail sign. The comet tail sign on an ultrasound in a gallbladder. This is classical for adenomyomatosis. This is classical for adenomyomatosis. You can see all these are your comet. The comet tail sign is your adenomyomatosis. So this is your adenomyomatosis. I can just point out here. All these are your adenomyomatosis. Now again in the gallstones you have two signs. You have the triradiate and the biradiate sign. The triradiate the triradiate sign is also called as the Mercedes-Benz sign. It's also called as the Mercedes-Benz. The biradiate sign, this is the Mercedes-Benz. This is, I'll say, the number one sign that you have. Second sign, which is here, this is what we call it as the seagull sign. So seagull sign is a biradiate sign. A biradiate sign. A biradiate sign is what we call it as a seagull sign. This is what we call it as the seagull sign. A biradiate sign is what we call it as the seagull, right? So this is with respect to all the gallstone images are going to be present, biliary images, right? This is about hyperparathyroidism. When you talk about images on hyperparathyroidism, what are the three images you have? Number one is your subperiosteal resorption, which is going to be present, bowing of the middle phalanx that you can see. So here you can see presence of subperiosteal resorption. That's the first one. It is most commonly seen in the middle phalanx and most commonly on the radial side. On the radial. Second image that you can see is the salt and the pepper sign. There is a salt and pepper sign. The last one that you can see is your rugger jersey. It is your rugger jersey. So in a rugger jersey spine, this is the vertebra, and you see this is loss of calcium here. So alternate bright and dark. So it is giving a classical rugger jersey spine appearance. Okay? It is seen in hyperparathyroidism. In the pancreas, again a quick succession. A patient with double bubble sign for a pancreas, where do you see? A double bubble sign in pancreas, it is usually seen in annular pancreas. It is usually seen in annular pancreas. So if you see a CT image of an annular pancreas, I don't think for an undergraduate they are going to ask you. So this happens to be the duodenum and this happens to be the pancreatic tissue, and this is your annular pancreas. Now remember, the most common is going to be the junction between the second and the third part of the duodenum, where the rim of the annular pancreas is usually formed, right? Now in an acute pancreatitis, the first thing you will see is presence of sentinel loop sign. Sentinel loop sign. This is seen in acute pancreatitis. Seen in acute pancreatitis. Then this is like an abrupt out of colon. This is what we call as the colon cutoff sign. This is what we have of the colon cutoff sign. So when you have a colon cutoff sign, in a colon cutoff sign, this is again seen in acute pancreatitis. Also seen in acute pancreatitis. Now this is again an interesting image where you can see this is the pancreas which is present here. Right? This looks like this. Normal pancreas will have this hazy margin. is how a normal pancreas would look like. So a normal pancreas will have this hazy margin. So loss of this hazy margin is what we call it as a sausage shaped pancreas. Now a sausage shaped pancreas. A sausage shaped pancreas is seen in autoimmune pancreatitis. This is seen in autoimmune pancreatitis. This is seen in autoimmune pancreatitis. And the most common antibody responsible for this is your IgG4 class of anti. It is your IgG4 class of anti, right? Now, this is an image of an ERCP. Now, remember, ERCP is the investigation, I can say the gold standard, sorry. ERCP is the gold standard. It is the gold standard for chronic pancreatitis. For chronic pancreatitis. What is the investigational choice for chronic pancreatitis? It is nothing but uh, for chronic pancreatitis, it is MRCP with secretin stimulating study. MRCP with secretin stimulating study becomes the investigation of choice. Now the image that you see here, this is what we call it as the chain of lakes, or also called as the chain of lakes or the string of beads appearance is seen in chronic pancreatitis, right? Absolutely correct. Now, where do you see a double duct sign? A double duct sign. You can see this is one duct, this is one duct. This is usually seen in pancreatic head cancer. Double duct sign is seen in pancreatic head cancer. Same side, if you do, and you go ahead and do a contrast imaging, you see this like this is what we call as the inverted. The inverted 3 sign is also seen in pancreatic head malignancy. It is also seen in pancreatic head. Also seen in pancreatic head. Right. So these are all the images that you should know from a general surgery standpoint. I know it's quite extensive, but we try to cover every single component that is available from the general surgery standpoint to all the way to the images down to your hepatobiliary pancreas as well, right? So thank you so much for joining. If you have any questions, any queries, feel free to reach out. Otherwise, just go through this entire image performer once. I will share this entire PDF on my Telegram channel as well as on my Instagram channel and on the PW's channel. And those who wants to know where you can find mine is at the surgery guide. You can find the notes on the surgery guide. Now this is by the channel is by my name, that is Dr. Sandeep Seeram Reddy. This is, you got both Insta as well as Telegram. And of course, you can find them on our PW MedEd channel, right? So प्रज्वल scores और staging का एक session है. There's again going to be a 3-hour session where you're going to talk about all the scoring systems in the surgery, all the classifications in surgery. Along with that, we'll also take about all the TNM classification staging of all the cancers. Okay. So until then, thank you so much for joining. Today it was specific about images so that you give a brainstorm of all the images which are going to be important from our exam point of view, right? So I hope you prepare well, right? If any questions, any queries, reach us down. You know where to reach us out. This last few days for your exam, you need to be absolutely concentrated. Everybody is going to tell you the same. I'm going to tell you the same as well. But remember, do not try to read much. Try to revise it again and again and again. The revision is the key. Start doing questions. You need to start doing in the last 1 month of the exam at least 200 questions per day. You need to hit that magic mark so that your score improves and your rank as well, right? So thank you so much for being patient and joined the whole session. I mean, great company from you guys. I'll share the PDF right after this class only. I'm going to do it as the class continues, right? Until then, thank you so much. Good day. Take care. Read well. Bye bye.